Good evening, everyone. Welcome and to the MyCP webinar series. My name is Paul Gross, and just to give you just a quick overview of how these fit into the Cerebral Palsy Research Network and whatnot. These are a set of community-focused presentations where the investigator of one of our studies describes the work that they're doing, the findings that they've made, or future plans for studies to try to create a dialogue. In general, presentations are about 20 minutes, and then there's open Q&A. So that is the process. Tonight we have my quick overview of the Cerebral Palsy Research Network, or CPRN. I'm actually going to mute everyone, so just hold on one second.
No, it's only their email. I have got their mobile phone.
Okay, so I've muted everyone, so if you need to unmute to ask a question, you're going to have to manage that on your own. Okay, so I'm going to give a quick overview of CPRN and MyCP, and then the main course for tonight is Dr. Adam Ostendorf to talk about cerebral palsy and epilepsy, two commonly co-occurring conditions, and some great work that he's been doing to enable the study of epilepsy in people with CP through CPRN, and then we'll have open Q&A. So just a reminder on the mission for CPRN, it's to improve outcomes that people with cerebral palsy value most through high quality clinical research and quality initiatives. So that people with cerebral palsy value most is because we did a patient-centered research agenda called Research CP. It's on our website, it's free to download, you can read it, and that drives the research agenda for CPRN. So what is CPRN exactly? It's a collaborative network. It's not actually an entity, it's a set of people, hospitals, clinicians, people with CP or caregivers, researchers that have come together to improve outcomes. The only sort of physical entity besides the work happening in every hospital is a data coordinating center, or a place where the data for the work we do that comes in, and that's the University of Utah, where I'm an associate professor. And there's two core pieces of infrastructure that are there to sort of accelerate and enable our research. There's a clinical registry, and by clinical, I mean it collects data when you're at the hospital. And what the kind of data that it collects is characterizing patients and the interventions and treatments they receive, as well as the outcomes. And what's special about it is it's built right into the electronic medical record, which gives us just a lot of ability to have data without having to do double data entry. And then there's a community a community registry that follows both children and adults long-term. MyCP is a web portal. So it's a website, mycp.org, that you can go to, that's owned and operated by CPRN. And it's really intended to bring the extended community into a discussion about research. And so today the portal offers the ability to participate in research from your computer through a set of surveys that are hosted in what's called our community registry. There's a forum for discussions about research, although we wander off into all sorts of other interesting topics about living with CP and treatment and providers, and we have a number of providers that are there, so it's a great place. We very often bring people in to get questions answered, so it's a great place to sort of get a professional view about the best evidence or the best practices in care. It's news. News is very focused on CPRN studies. And we're starting to build a set of tools to enhance care. The first tool happens as you sign up if you're a person with CP or a caregiver, in that it tells you what your gross motor function classification system number is. And there's been some research that shows that not everybody knows what that is and why it's important. So we give you that number, and then we give you a reference to a document that will help you understand the importance of it. So if you're not already a member of MyCP, I would suggest you consider going to MyCP, read about it, and sign up. A couple other things quickly. This is our research pipeline. We have come together over the last 5 years to really try to accelerate research. So the wide end of the funnel are new ideas that are being moved along through to getting approvals, applying for funding, being implemented. I see the speech and participation one is now in the study execution phase. I need to move that forward. And tonight we're going to be talking about this one that has a gray circle around it, which is epilepsy infrastructure and the findings that have come from that. And then after we conduct studies for a period of time, we try to generate manuscripts or papers about these things and publish them in journals, and then hopefully take that learning and implement it back into the network of hospitals that participate. So the network's quite broad. I actually have to update it. Didn't have time to update it, but we've actually added a number of these candidate sites have actually crossed the threshold into being new sites recently, including St. Louis Children's, Shirley Ryan Ability Lab, Akron Children's, Columbia in New York, and I know I'm leaving off one, but a number of new sites. Oh, and Cincinnati Children. So Ohio is getting the award for most centers in their state. They're competing with California. So there's more details at cprn.org. So on to our featured speaker. Dr. Adam Ostendorf is a pediatric neurologist at Nationwide Children's Hospital. He's also an assistant professor of clinical pediatrics and neurology at Ohio State University Medical College. And he is the principal investigator, or PI, for a relatively new group for CPRN, which is the Epilepsy Study Group. And that goes hand in hand with a grant that he received that's entitled Enhancing a Multidisciplinary Research Network for Researching Quality in Epilepsy and CP. And that was awarded to him. That was $200,000 awarded to support the development of this infrastructure by the Pediatric Epilepsy Research Foundation. So without further ado, I turn it over to Dr. Ostendorf. Adam, I assume let me stop sharing and then maybe you can take control more easily. And I don't know if I have to unmute you.
I unmuted myself, thanks.
Oh, look at that, the control is great.
All right. Can everybody see my screen?
Yes.
Perfect. All right, well, thanks, Paul, for inviting me to give the webinar tonight. I really have to say a huge thank you to both you and all the other people who have really gotten CPRN up and off the ground. This is an amazing opportunity to learn more on how we can take care of people with CP and pay attention to all of the different relationships between their cerebral palsy as well as their comorbidities. And this is just an absolutely awesome network full of really energetic people who are incredibly intelligent, and I'm very lucky to be a part of it. So thank you for graciously inviting an epileptologist into your mix. Tonight I'm going to be talking about our work focusing on the study of epilepsy in people with CP. So first off, I just wanted to give a quick background on epilepsy. So epilepsy is a condition where people have recurrent seizures. So after you've had 2 seizures, pretty much that meets the definition of epilepsy. And it's really common. Epilepsy occurs in about 1 in every 26 people. And there's a large number of children who develop epilepsy, and some of them may outgrow it. And then there's a large number of older adults who develop epilepsy. But in general, you have about 1 in 26 chance of having epilepsy. And certainly it occurs in people who have other brain conditions like cerebral palsy. And so it goes hand in hand with a lot of those neurological disorders. And what seizures are is they're just brain cells and groups of brain cells that are making too much electricity. And this is an example of something I look at an awful lot every day, which is an EEG. And this is a 15-second page and looking at the electricity over different brain regions. And this is what a seizure looks like on EEG, where you have this rhythmic, abnormal electrical pattern. And that can be something that looks like a staring spell. It can be a whole body convulsion. But we know that epilepsy is really impactful to people's quality of life as well as their overall health. And its influence on somebody's ability to enjoy their life is really outsized when we look at many, many other factors. And so one of the main things that those of us who take care of folks with epilepsy really drill down on and focus on is quality of life, and balancing in treatment and the condition. How do we treat epilepsy? Again, very, very common, but caused by many, many different things. And so first off, we almost always start with anti-seizure medicines. Now, anti-seizure medicines are pretty decent, but they're not awesome. So if I have 10 kids in my clinic with epilepsy and start all of them on a seizure medicine, that's going to control only 4 out of 10. So I add another medicine and maybe we can control 6 out of 10 seizures. But 4 folks are still having seizures. And if we try lots and lots of medicines, 4, 5, 6, 7, 8, 9, 10, 15 different medicines, we may only get 1 more person seizure free. And so then for those 4 out of 10 folks, we consider other options. Typically those options are epilepsy surgery or ketogenic diet. And this is really important for folks who have cerebral palsy because we know that their seizures can be difficult to treat, and we know that dietary therapy can be helpful for them, although has potential problems for other comorbidities like bone health. And we know that epilepsy surgery can be really, really effective in an appropriately chosen person. So this is an example of somebody with CP who had a stroke when they were a baby, and this is what we call the right MCA territory. So this is the right part of the brain, and this person was very weak. They had left hemiplegic cerebral palsy, and the seizures typically come from those areas around that that brain lesion. And what we do in that case is to do what's called a hemispherotomy, where we disconnect the bad area of brain around it. And you can see that here in this picture next to it. This has been disconnected. And those people who have had really, really tough to control seizures, they often, 90% of the time will get rid of their seizures completely with this kind of a procedure. And so again, you have to really choose who you're taking care of in this way. But this person had, weakness on the left side before the surgery, a huge disconnection surgery, and same weakness on the left side after surgery, but now they don't have seizures anymore. And so that can be really life altering. And so we need to find out, how do we take care of folks with CP and epilepsy, and how do we identify those that we can really impact in that way? And so that led to an opportunity to think more about, epilepsy in folks who have CP. And, epilepsy is really common in general, and it's very, very common in individual CP. So 35 to 50% in epidemiologic studies where they've looked at like single country registries or insurance registries. And they've also found that seizures tend to be really difficult to treat, more so than if somebody doesn't have cerebral palsy. And we know that you treat epilepsy and you may make a comorbidity worse. So our anti-seizure medicine may help headaches, but may worsen bone health. And that may make somebody's cerebral palsy worse because they may then develop a fracture and be immobilized even longer. And so all of these interactions between epilepsy and its treatment, CP and its treatment, comorbidities in their treatment, are really, really confounding. And there really hasn't been a way to delve into that and start looking at those interactions, quite frankly, until the CPRN registry. And so, in individual CP and epilepsy, we don't know things like how often do people have seizures despite multiple medications, how are people with CP treated compared to other people without CP, and what is the relationship between CP, epilepsy, and those comorbidities. And again, this is a common problem, and it's been around for a really long time, but there are very few scientific papers on how we can take care of these folks in the best way to optimize their quality of life, their seizure control, and their safety. And that's where the CPRN data registry came in. And again, Paul and Gary and the early investigators with the CPRN data registry were really forward thinking when they developed this practice-based registry where information is collected during a clinic visit that can then be used for research. And so you make everything more efficient. And one of the things about CPRN data registry, and I'm part of a couple other data registries, but the unique thing that that CPRN has over other registries is how multidisciplinary it is. You have developmental pediatricians, physical medicine doctors, therapists, surgeons. You have this huge group who have unique ways of looking at a person with CP, and all teaming up together to put their expertise and slivers of their expertise into this data record. And that is a really unique strength to CPRN. It also creates a little bit of a challenge when we're asking, a developmental pediatrician to gather information on epilepsy. And so when we first started this project, we had to be very intentional with how we asked the seizure questions, and we wanted to be efficient so we don't take too much time, but gather meaningful information. And so that was a major part of the initial project. The other small slice of this that may get larger over time is something called a learning health system. And so that's a system where you gather data, but then in near real time, or as the practice, as the patients are taken care of, you deliver knowledge from the system back to the point of care. So you can take information that you're gathering on those forms during the clinic visit and use that to remind a provider to, hey, this patient doesn't have this medicine on, maybe you'd want to consider trying it, or this person may benefit from something like an SDR. Is that something that you'd consider discussing with the family? And so you can create this learning health system that we're gathering information and using that information in an iterative process. So the Pediatric Epilepsy Research Foundation is an absolutely outstanding organization that is trying to fund meaningful infrastructure research where an investment can then turn into an ongoing research project that is meaningful over time. And so they very graciously awarded us one of their main annual awards. And we were able to use that money to kind of tweak the CPRN registry to study epilepsy alongside cerebral palsy. And so again, during that clinic visit, practitioners are putting data into the clinic note, into the EHR, the electronic health record. And then from that, we can learn a lot. So we can describe the cohort. We can write a descriptive analysis that says that people with CP also have epilepsy, and these two things go together, and they're often associated with these other things. And hey, you've got, people need to be aware that they should look out for these other things. And so it's very, very important that that this is all being collected together. That from there, we can also then start picking apart different cohorts within the registry and look at comparative effectiveness research and try to compare one treatment to another or one diagnostic test to another. And even further down the road is hypothesis-driven research, where we're able to use this infrastructure to prospectively enroll patients and learn more in even a higher quality manner. Additionally, part of the learning health system, again, is using that information back at the bedside or at the point of care. And that's where decision support comes in. So you can create decision support within records where, I might be seeing a patient and, I click on the button that says the patient has had a seizure in the last month. And, the EHR can then look at their med list and say, oh, they don't have a rescue medicine. And as I'm going through the visit, a subtle prompt can come up that says, hey, this person has active seizures. They don't have a rescue medicine. Is that something you might want to prescribe? Now, we have to balance that because too many of those really make it hard to get through a clinic appointment. But meaningful, high impact prompts can really help not only gather the data, but then turn those data into improved care in near real time. And so then you can do that. You can study the effects. Hey, since we did this, now patients are coming to the emergency room less and having fewer longer seizures. Hey, that's awesome, but we could tweak it by doing this. And you can iteratively improve your practice at the same time you do research. So we are incredibly lucky to have a really active network that is becoming stronger each month, it seems. And so far, as of a couple months ago, the cohort consists of over 2,000 individuals. Over 600 of them have epilepsy and CP, so that's about 30%, which is about what we would expect, and that's across 9 sites. And you can see that by age, there's a big, bell curve, essentially, of age distribution. And as time goes on, we hope that this will sort of fill out towards those edges, and we'll even get more information about younger children and adolescents and young adults, as well as older adults. And so we're able to understand more about who has epilepsy, so maybe when it becomes more prevalent, as well as who, do people who have, symmetric cerebral palsy or bilateral cerebral palsy seems to be more associated with epilepsy, but is not, is definitely still prevalent enough in the unilateral that we need to, that we'll be able to get good information. This is an interesting bit of information that we're getting out of the registry, where we're looking at epilepsy and cerebral palsy etiology. And so just like epilepsy, cerebral palsy, as you know, can be caused by many, many different reasons. So somebody could have had a stroke when they were inside the womb, or when they were a brand new infant. They may have gotten an infection, or their brain may have formed incorrectly due to a genetic problem with the instructions on how to build a brain. And we're noticing that there are definitely risk factors from an etiology standpoint with regards to epilepsy. So, folks who have brain malformations or congenital infections tend to have a much higher incidence of epilepsy, whereas those with paraventricular leukomalacia, which is typically white matter, have lower incidence. And this would make sense because white matter doesn't cause epilepsy, but certainly cortical malformations or damage to brain cells on the outside of the brain can lead to epilepsy down the road. But this creates interesting questions like, why is that? Why do congenital infections have higher risk for developing epilepsy than those with congenital stroke? Because that is unexpected. So the information we're getting now is sort of describing what is going on, and then the why is going to have to come later. But it certainly is, we're developing more questions than we have answers for right now, which is always sort of fun and frustrating at the same time when you are doing research. Along with all these other pieces of information, we're learning that those who have a higher function have a lower risk for epilepsy, as well as those who have more severely affected function by the GMFCS, they're more likely to have epilepsy. And this makes sense, and it's certainly been described in the literature, but the amount of detail and the number of folks that we have and the high quality of information we have is certainly unmatched in the current in the current literature. We also know that those who have more severe motor function affected also have harder to treat epilepsy compared to those who are less severely affected. Out of all of the information that we're getting out of the registry right now, this is probably the piece that's raised more questions in my mind than anything else, and as well as concerns, and has prompted essentially another grant application to try to answer this question and similar other questions. So this is a table of how people are being treated for their seizures, and the why they have CP, and also probably why they have epilepsy. And you can see medications are really common, right? 90% of folks are on medications. A small number of people are treated with ketogenic diet, a small number of people are treated with VNS, and an even smaller number of people are treated with epilepsy surgery. This goes against what we know regarding the treatment of epilepsy. So we know that 30% of people are usually seizure-free on aren't seizure-free on medications. So in this patient population, why is the surgery rate so low? Especially in this area where these folks, I would anticipate, would really respond well to epilepsy surgery. So is this an access issue? Is there some other reason why folks with CP aren't being treated with epilepsy surgery? This is, again, raising a lot of questions that I really hope to answer over the next few years. In addition to understanding more about epilepsy and CP, we're also seeing data about comorbidities like hospital admission. So epilepsy is definitely associated with having a hospital admission in the last year, having gastrostomy or so feeding problems, and then certain types of seizures like generalized tonic-clonic seizures or full body convulsions. Those are definitely associated with a high risk of having overall hospitalizations. And so, the epilepsy impact on quality of life is definitely being elucidated with this kind of a project.
Adam,
Yeah.
Would you just go back and say what RR and CI for people in
yeah, sorry, I apologize. So this is relative risk. So, and this is a confidence interval. So these are statistically significant, meaning that if you have epilepsy, you are more likely, your relative risk is 1.3, and it's a tight confidence interval, which means that because of the volume of data in the registry, this is, you rarely get confidence intervals that are this tight. And again, that is really based on the fact that the registry is really high quality data, and it's a lot of it. So you are more likely, definitively more likely to be admitted to the hospital in the last year if you have epilepsy. And same thing if you have a gastrostomy, you're much, much more likely to have a gastrostomy than not if you have epilepsy. And with GTCs, because we don't have as granular data on the GTCs, the confidence interval is wider, but it definitely is statistically significant and a concerning, it's concerning, but it's also a target for intervention. So one question that will come up is, okay, so we see this association now. If we intervene on that, and if we can really target the GTCs and make those go away, does the relative risk for hospitalization now go down in that cohort? Can we make somebody's quality of life better and that person safer if we really focus in on this thing, this GTC type of seizure? So far on our initial grant, we're about a year and a half in, a little bit over a year and a half. And, again, a lot of this is built on the backbone of CPRN. And so the data collection, this is maybe better with the project that we've done, but the backbone of the CPRN registry is outstanding, and that work had been laid before we became involved. So, it's great that we're getting to be a part of it. And I think we've tweaked some things, but again, this kind of data collection is really due to the fact that Paul and all the other kind of founding group was really forward thinking with setting this registry up. So we know that 30% in the cohort has epilepsy. We're learning risk factors for epilepsy and comorbidities. Now we're getting more granular data, so more fine information on seizures, and we're getting that over time. And we're seeing some emerging things like seizure control and CP type and things like epilepsy surgery access. So, you know, you ask a question, you get some answers, and now you have a whole lot more questions. So our next step, so we did submit another round of funding to PERF that hopefully we'll hear back from over the next few months. And that idea is we want to now answer some of these questions in more detail. So they've come up now. How do we answer them? And a really important tool in research, especially thinking about epilepsy, is patient-reported outcomes. So how do you measure the impact of an intervention on quality of life? And there's a lot of different tools, and there's the CP Child, which is a fantastic tool. There are epilepsy-specific tools, and so we're building those and trying to sort out how best to use those in our patient population, so that we can send a tool, this survey, right, to the patient or the patient's family, and they can tell us what it means to them, like how is this condition affecting their life, both activity level, stress level, other health outcomes. And then we can track that over time and say, okay, we're doing a good job. This patient's quality of life is improving. The family quality of life is improving. Or, oh my goodness, this is getting worse. We need to ratchet up interventions. And we can look at that in association with all this other data from the registry and learn a lot about how we're taking care of folks, and are we doing a good job, or what areas, what cohorts are at higher risk for lower quality of life. So if you have GTCs, generalized tonic-clonic seizures, those folks are at risk for lower quality of life. We need to provide extra resources and be ready to intervene on these other things because of it. So that's a really, really critical next step in sort of beefing up the ability to know if we're doing a good job taking care of our patients. We also want to improve our data quality. Again, the CPRN registry is multidisciplinary, which is awesome. It also provides an opportunity to tweak how we get the information, and so that's one thing that we're looking to try to understand better and do better over time. You know, again, as an example, this is definitely not the only theme that's emerging from the initial study, but you know, we want to understand, for instance, why the surgery rate is low in individuals with CP and epilepsy in our cohort. Utilize and learn how to utilize decision support for something like an emergency medication, and that would kind of transition or add on the additional title of learning health system in this kind of a practice-based registry. And you know, so it's very exciting. I got, you know, quite frankly, this ability to understand these two conditions and comorbidities together, it hasn't existed before. The CPRN is an outstanding gateway to really understand how we can take care of these folks better, and I'm very, very thankful to be a part of it. So with that, I'll turn it over to Paul, and I'm happy to entertain any questions.
Great. Adam, thank you so much. I mean, I've heard you present this, but at a sort of warp speed, so it was great to be able to take it at a more digestible level, and it was great information. Let me open it up to questions. What I will say is I'm going to go with, if you could put your, can I put everyone's hand down? I don't think I can. Let me see if I can do that. Well, I'm going to lower all hands. Great, I've got control. So now if you want, you can raise your hand if you have a question, and I will call on you, or you can send the question via chat. And we did have a comment along the way. Adam, I imagine you were not able to see it in real time, but it was, what a fantastic setup. This should be spread internationally. Here, I agree. But okay, so I see some hands up, so I'm going to just go down alphabetically. Cindy Evans, if you can unmute yourself and ask a question, fire away. And Christy Bjornson, you're up next. Cindy Evans, I'm going to unmute you. Go ahead, Cindy.
Oh, thank you. Can you hear me?
Yes.
Mm-hmm.
Awesome. I couldn't find the unmute button. My question, I note that you've only got like 1.5% of people with cerebral palsy actually getting the surgery, but are you getting any information on the success of the people that actually with cerebral palsy that have the surgery?
Yeah, it's a great question. With the next iteration, or with this, I guess, most recent iteration of the forms, as they're being filled in, I think we'll get that information because it's practice-based. It takes time then to accrue the data. But I think based on the data elements we're collecting, we will be able to answer that. I think it will require a little bit more time to try to gather that information, as well as the additional infrastructure that we hope to build with the second grant to identify those patients and kind of ask more specific questions about those individuals in particular. But we are on the path forward in answering that question. I think we will get there maybe in about a year or so.
Cool, thank you.
Great. Christy Bjornson.
Hey, Adam, thank you very much. This was very, very exciting. I've heard parts of this, but it was great to see it in a broader perspective. And I agree, every time you ask a few questions, you come out with 25 more questions. So I totally appreciate where you're at. My question is a little bit, and maybe I'm a physical therapist. I'm not a neurosurgeon, but I've treated many kids who have had hemispherectomy who go on to have sometimes motor impairment that looks like hemiplegia or whatever. And oftentimes the history that I hear is intractable seizures was when they considered going to surgery. And is that part of, the decision for surgery to treat seizures? They have to be intractable and the child is just not functioning at all? Or I guess if you can help me to understand that a little bit, maybe that's part of the epidemiology we're seeing here, and that children with CP don't always present with intractable seizures, or later in life maybe they do. But anyway, just a thought and a question.
Yeah, thanks for that question. So the rate of intractability specifically in folks who have CP is not well described in literature. The papers that have looked at it more from like an insurance claim standpoint, but it does seem that people who have CP have tougher to treat epilepsy. The registry data will be able to answer that question as we accrue more data and as we get a few more sites up and running, which again, I expect that to really start emerging from the data set over the next year or so. The why is hard, right? So in children, so most of our data in the registry is children. Most data for CP and epilepsy come from the pediatric and adolescent literature. And in general, the epilepsy surgery rate in children is pretty low. If you look at it just across the board, there was a paper that was written a few years ago that looked at epilepsy surgery in children, and the rate was 0.14% of people of kids with epilepsy were getting surgery. And that, is opposed to a 10 to 15% rate of children who could potentially be cured with epilepsy surgery. And so there's a huge magnitude of distortion, and that is probably a lot. It's probably incredibly multifactorial. Now, if we get a little bit more infrastructure as far as the ability to do some surveys of providers and of families, I think we'll be able to maybe ask that question in a more complete way. Otherwise it's kind of the factors that seem to emerge just as a population in a whole are things like access to level 4 epilepsy centers that can do all of the testing and the types of surgery, as well as, some kids are really, so, if kids are non-ambulatory, there are certain practices that will then kind of rule them out from an epilepsy surgery perspective. And I think that is hopefully becoming less of an issue, because we do know that kids who are non-ambulatory, people who are non-ambulatory can still have tremendous benefit from epilepsy surgery.
Mm-hmm. Thanks, Adam.
Thank you.
So Adam, the next question is in chat and from J.K. Taylor, so I'm just going to read it. To reiterate, surgery improves epilepsy by 90%, question mark. Is this statistic similar to the surgery which removes the damaged brain tissue?
Yeah, so good questions. There's lots of kinds of epilepsy surgery, and in fact, there are, even in the last 5 years, we're using newer techniques and kind of more personalized techniques than, we were just 5 or 10 years ago, right? Compared to right now. So the classic, textbook person who comes in and has hemiplegic CP because they have a unilateral or one-sided brain malformation or stroke when they're a baby, 90% of the time, you can make them seizure-free with a hemispherectomy or hemispherotomy. One removes the tissue, hemispherectomy. That's kind of an older technique that is used less now. A hemispherotomy leaves some of the tissue but disconnects the entire hemisphere. The reason some of the tissue is left is just to make the surgery go faster, less blood loss. But the result is the same. And so, 90% of people will not have another seizure again if they have that kind of surgery. And, if they're able to get that kind of surgery and it, it's an appropriate one for them. Other folks, though, can benefit greatly from surgery that even is less than that. So, we use lasers to, through very small holes in the skull to ablate or vaporize bad brain tissue, and sometimes that can make seizures go away in people who have a lot of other brain injury, but you've just found the seizure spot. And that's a technique that is newer and that wasn't, really, used a whole lot even 5 years ago. And so, and it reduces risk. And so now you can take a kid who would be a higher risk to do an open brain surgery. So people might shy away from it. Somebody who might have, severe scoliosis and quadriplegia, and the risk benefit now tilts in their favor if you can do, a tiny, minimally invasive brain surgery and make their seizures better. And that's a paradigm shift, but it is absolutely something that a lot of folks are doing more and more often. And, anytime you can reduce risk but potentially provide benefit, I think it's a win.
Great.
Yes.
I'm sorry, are you done, Adam?
Yeah, sorry. I hope that answers that question.
That's okay. And I accidentally sent you I meant to send you a text when you were done, and I am so automatic. I sent in the middle of you speaking, so I hope I didn't distract you. John Borland asks, regarding treatment, is surgery possibly low as compared to medication simply because treatment for CP seems to still be, I'm probably reading this wrong, so assumptive. Doctors doing what they've always done as opposed to looking into new treatments?
So I guess what I would say to that is that epilepsy treatment, there is, pushing the envelope with a lot of a lot of areas of epilepsy treatment, especially epilepsy surgery, kind of more so than anything else. We still do use really old school, ketogenic diet's been around since the early 1900s. I think it's more of an understanding that we should be applying them in different ways. So, again, balancing risks and benefits. Maybe there's newer, safer ways to do those surgeries for a broader population. I'm really narrowly focused on epilepsy in my practice, and I'm pretty passionate about making seizures go away. And so I think that right now that's our best tool. Certainly there are other things in the pipeline, medicines and other like neuromodulatory treatments. But from an evidence-based standpoint, really the thing I can do for my patient right now, and without enrolling them in a study, is to offer them treatments that we know work. And that's why we should be considering epilepsy surgery for individuals with tough to treat seizures at this time, unless there's a study to enroll them in.
Well, I really look forward to you being able to answer the why are they not getting it and learning as much about that. Dr. Ostendorf, thank you so much for your time. I greatly appreciate it. I greatly appreciate your passion and what you've done to bring a new discipline into CPRN. I'm just going to wrap by saying next webinar is on Tuesday, June 2nd at 8 p.m. And this character, Paul Gross, is going to talk about practice variation in selective dorsal rhizotomy. So I actually interviewed the physical medicine doc, the orthopedic surgeon, and the neurosurgeon at 13 hospitals across North America with a series of open-ended and closed-ended questions, and looked at how they made decisions about doing SDR, whether or not to offer it, and sort of their whole process. And so I'm going to share the results of that qualitative research next month. So we will continue that. An invitation for that will go out to everyone that signed up for the webinars. So thank you everyone so much for your time. Thank you, Dr. Ostendorf. It's really great having you advance this area that's so important for so many people with CP. So everyone have a good evening. Stay healthy, stay safe. We'll see you next month on June 2nd.
Take care, Paul.
All right, thanks. Bye.
Thanks, Paul.